Good afternoon, everyone. This is the California Elder and Disability Justice Coordinating Council stakeholder meeting. We're going to wait for everyone to join. And if we have the ASL interpreters, if you could raise your hand, I can move you over to the panelist side. Oh, it looks like you're here. Let me find you. There you are. I'm going to spotlight you. Hi there, nice to see you. Okay, great. Let me lower your hand. Okay, I'm going to make the interpreters. All right, looks like we have everybody in the webinar. Good afternoon. Again, thank you for joining us. This is the California Elder and Disability Justice Coordinating Council meeting, or EDJCC. My name is Carol DeAndres, and I'm the Stakeholder and Public Engagement Manager here at the California Department of Aging for the Master Plan for Aging team. Thank you for being with us. Today is October 17th, and this is EDJCC's final committee meeting of 2023. Where has the year gone? I'm going to go ahead and go over some logistics. So if we can go to the next slide. Great. As you can see, we have American Sign Language is available. We also have closed captioning available via the Zoom functions. The meeting slides, the video recording, and transcripts and any meeting materials will be posted to the EDJCC webpage once we're finished with this. And let's go to the next slide. Oh, EDJCC members, committee members, panelists, if you haven't done so already, please rename yourself. Right now, your display is EDJCC panelists. So if you could hover over the top right-hand corner of your Zoom picture, you see 3 dots, right-click and hit rename, then we know who has joined us today. Thank you so much. We will have a public comment period later in the agenda. Public comment is limited to 2 minutes allocated for each comment. Attendees joining by the Zoom function can select their raised hand icon and we will go ahead and unmute you. And if you're joining by phone, please press *9 on the dial pad to raise your hand. We will unmute you. And of course, you can provide us comment at any time to the Engage email box, which is engage@aging.ca.gov. So now I think we can go to the next slide. And I'm going to turn it over to my colleague, who is the Elder Justice Specialist here at the California Department of Aging, Ranjana. Ranjana, please go ahead.
Thank you, Carol. My name is Ranjana Maharaj, and like Carol said, I am the Elder Justice Specialist here at the California Department of Aging. I will be going over the council purpose, equity guiding principles, and today's agenda. The council purpose, the goal of the Elder and Disability Justice Coordinating Council is to increase coordination and develop recommendations to prevent and address the abuse, neglect, exploitation, and fraud perpetrated against older adults and adults with disabilities. Next slide, please. Our equity guiding principles serve as our North Star and on how we're building a healthy California for all, where every individual belongs to a strong and thriving community, where older adults and adults with disabilities can live with purpose and dignity, and where they are supported and valued. I'm going to go ahead and read the equity guiding principle. We recognize that past, current interventions and services to prevent mistreatment have had negative consequences for some victims, families, and communities as a result of systemic discrimination and biases. To counter these negative impacts and to ensure equity and inclusion moving forward, we are committed to letting the following principles guide all aspects of our work in planning, coordination, and program development. Next slide, please. We recognize that all adults deserve to live free from abuse, neglect, and exploitation. We acknowledge that the existence of systemic racism, discrimination, and negative impacts. In order to combat these impacts, we must center equity at all stages of our council's work. Centering around equity does not just mean creating equitable solutions for older adults and adults living with disabilities, but also recognizing that implicit bias exists within all of us. And we are committed as a group to acknowledge and explore biases while doing the work of this council. We acknowledge that while older adults and adults living with disabilities have many overlapping interests, they are distinct communities, and any policies that are observed or recommended by this council should examine impacts to each community. Lastly, we recognize the importance of hearing directly from older adults and adults living with disabilities. Their lived experiences should always be the center as we move forward with the work of this council. Next slide, please. We do have a packed agenda, and we will be starting with opening remarks by our CDA director. And then we will go over the Building California's No Wrong Door system, and updates on California 2030, as well as ADRC expansion. Then we'll delve into our Elder and Disability Justice Coordinating Council work group updates, which is led by our Vivian Mabaku, Jim Trigari, Akili Saran, and Bertha Hayden. Then we will go ahead and have an overview of the Office of the Long-Term Care Patient Representative by Susan Rodriguez. We will have a short 10-minute break. After the break, we will have Lee Bills from the California Department of Emergency Services Victims Branch provide some updates for the programs that they have, followed by Regina Wright from the California Department of Aging, the State Public Guardian Liaison, followed by public comments, and then closing next steps. At this time, it's my pleasure to introduce our CDA Director, Susan Demaris, who is also the State Chair for the Elder and Disability Justice Coordinating Council, along with Eric Dowdy from the Alzheimer's Association, who is the co-chair.
Great. Thank you so much, Ranjana, and welcome everybody. Good afternoon. It's great to see your faces gathered on the screen, and there's so much work behind every face that I see. This is one of our hardest working stakeholder groups with the work groups in between meetings. So I'm really excited to hear the reports out today and to hear from members who've gathered. I wanted to start with just there's not enough good news in the world today. Or recently, but a bit of good news. I wanted to recognize the California Elder Justice Coalition's $328,000 grant award from the National Center for State and Tribal Elder Justice Coalition. So congratulations to the leaders in our state who worked so hard to put that competitive grant application together. And that's a tidy sum of money to support the outstanding work that you're doing. So congratulations. I also wanted to extend a special thanks to our colleagues at the Department of Social Services and to our state long-term care ombudsman, Blanca Castro. We are all working in collaboration with one another and independently to provide comments to the Administration for Community Living. For the first time ever, they have opened up for public comment the APS regulations at the federal level. There has never been a public comment period before, so we're working together to submit comments so that California and the work of this council can be represented, as well as the work of
Susan has frozen for us at the moment. Let's see if we can get Susan back. Oh my goodness.
While Susan's waiting to come back, I'll just finish. I think her thought was That's what happens when you work so closely together, is that with the proposed regulations first ever, that the purpose is for adult protective services to be uniform across the country. And we're excited. So as everyone knows, Department of Aging and the ombudsman are able to submit comments. And so the long-term care ombudsman will be submitting comments independently from the Department of Aging while we're housed with the California Department of Aging. They are a state agency, and so they will be submitting their own comments, and we will be focused on our separate comments, and that is yet to come, but very excited, and they look very good. Is Susan back yet?
Don't see her right now. Anjana, do you want to go ahead and let me bring you on.
Thank you. No worries. While we're waiting for Susan to come back, let's go ahead and start with the Elder and Disability Justice Coordinating Council Work Group updates. I'd like to introduce everyone to Vivian Mabaku, our Equity Director, Justice and Aging. The Equity Director for Justice and Aging, who serves as the Legal Services Chair. We have Jim Trigari, the APS Administrator for Department of Social Services, who is our APS Chair. Akili Cerrone, the APS Director for the City and County of San Francisco Human Services Agency, who is the Co-Chair for APS. And Bertha Hayden, Directing Attorney from Betsadec, who is a Conservatorship Chair. Vivian, if you'd like to start the updates.
Yes, I'm not sure if I can't see myself, so I'm not sure if I'm highlighted or not.
There we go.
We
How
can
about
see
now? Go ahead,
You can
Vivian.
if you can please go to the slide for the updates. Next slide, please. Thank you.
Awesome. Thank you, Ranjana. So I am Vivian Mbaku, and I am the chair for the Legal Services Subcommittee, and I have a few updates. So our Legal Services Subcommittee has been really busy at work. One of the things that we've done over the past few months since our last council meeting is that we did meet with a group of directors and administrators of medical legal partnerships and MDTs throughout California to discuss how legal services attorneys and legal services organizations could be better integrated into MDT work. And that was a really beneficial meeting to understand just the variety of ways that MDTs are being administered throughout the state and how legal services can really get involved in that work. So those are going to be ongoing discussions. And then the big update that we have is that the chairs of the three work groups, legal services, APS, and conservatorship, are meeting monthly to make sure that our work is coordinated. And through those meetings, we as the legal services group came up with some specific goals that we have for our work for the next year. So our goals are really focused on funding. We all agreed that the work that legal services attorneys do throughout the state is really great work, but a lot of it is restricted by the types of funding that people have access to funding, what the funding is for, like specific areas of law. So we're really looking at ways to get more funding to legal services attorneys. So creating new sources and finding new sources of funding so that they can better serve older adults and people living with disabilities. And then also making sure that people are aware of existing funding sources. We did have a representative from the California State Bar talk to us about IOLTA funding, and that's funding that's from the interest on lawyer trust accounts, and how they actually don't see a lot of organizations that serve older adults applying for that funding. So we're looking at ways to make sure that people are aware that IOLTA funding is available for them. And then also enhancing the legal services workforce. Legal services workforce often has really high turnover. Legal services attorneys tend to make less money than private attorneys. And then we also believe there may be some data that shows that legal services attorneys from organizations serving older adults and people with disabilities may have lower salaries as well. And combining that with the very large student debt burden that anyone who has been to law school has, we are looking at ways to support the workforce, support student loan debt forgiveness, or potentially programs that really help people exit law school with less loan debt so that they can serve these communities, and really just looking at all the options that we have available. And in addition to that, we are looking at ways that we can support legal services organizations providing the type of legal services that clients need. In particular, looking at wills, trusts, and other types of probate documents. We know that a lot of older adults are seeking these types of legal services, but there's a limited amount of lawyers who are able to do that type of work. And there's a limited amount of legal services organizations that do that type of work. So we are currently investigating why that is, how we can support legal services organizations who do that work, how we can increase the funding so that they can do more of that work, and really focusing on how do we provide funding so people can do full service work, not just individual clinics where people kind of get basic advice. How do we actually get full representation and fund full representation for those clients? And that is my update. Thank you.
Thank you, Vivian. Funding is truly an important aspect of the work that we're doing. So thank you so much for bringing that information and providing that update. I would like to now turn it over to our co-chair for the Adult Protective Services, Achilles Cerrone, San Francisco Human Services Agency. Jim will be joining our meeting later. He is in the meeting. Achilles, there we go.
Hi, thank you, Jenna. So I'm the Director of Adult Protective Services, the program within the agency of Human Services Agency. I just wanted to clarify that. And the work group met to discuss a number of issues that APS has been facing in terms of what are some of the improvement areas that we can target so that we can become more effective as an intervention mechanism, and also as a mechanism that can support independence and maximize decision-making on the part of our APS clients. With respect to the proposed federal regulations, I know that the state CDSS, Jim, and the California Welfare Directors Association have met and enlisted the input from counties, 58 counties, 58 APS programs, so that this can be shared. And so we're very excited about that. And with respect to the landscape analysis and what is needed in the field of APS, we looked at some of the basic aspects of how reports are made, reports of suspected elder and dependent adult abuse in California, and whether all the cross reports are being made as required by the California Welfare Institutions Code. And some of the findings through this exercise that we came across is that not enough cross reporting is being done to get the appropriate state agencies and other partners involved as they should at the beginning of an inquiry when we are trying to design a way to intervene. So the work group is thinking through some concepts like a one-door cross-reporting system where a report can be made to one entity within a jurisdiction, and that report can be not only screened for the immediacy of the response, but cross-reported to the other agencies that need to receive that cross-report, and to do that consistently for all types of abuse, in addition to screening for any type of immediate local services available to help intervene and ameliorate the harm to our client. And we also identified some areas where there is existing language in code that allows for collaborations and that appears to facilitate collaboration between APS programs and legal aid services. For instance, an example it is with restraining orders, for example, and how to pursue some of these more effectively through collaborations. Also, with respect to older adults, adults with disabilities, when we talk about abuse and harm, we're talking about the person and the estate, or the property of the person, whether it is real or personal property, and how do we intervene? A lot of the concepts or models for intervention rely on a multidisciplinary team. So we think that through the one-door cross-reporting system, more multidisciplinary team collaboration can happen with a focus on intervention, as other agencies would have received a report, and maybe more collaboration can bring more expeditious intervention to keep the person and their property safe from harm, from abuse. And there are other sections of in California codes that permit the collaboration between APS, local law enforcement, and the public guardian to design ways to intervene timely for both, to help an individual receive the medical attention that they need, which in many instances can improve their decisional ability, which in turn is consistent with supportive decision-making concepts, which is one of the areas that is being explored, not only federally, but here in California. And also interventions when the estate, the property of the older adult, the adult with a disability, is at risk of being lost, harmed. And how can we intervene in a manner that saves and helps protect that on behalf of the older adult, the adult with a disability, and to give them the opportunity to bring in the resources in their place, as independent as possible, that will improve the functional ability and will improve their decisional ability, which is also consistent with supportive decision-making values that we're seeing as desirable here in California. So that is my update. Thank you, Ranjana.
Thank you, Achilles. Very truly important work, and being able to have our APS work group work on, availability of services and transforming the way it's accessible to older adults and adults with disabilities, and looking forward to the work that's moving forward with this work group and legal services. So thank you. At this time, I would like to also introduce everyone to Bertha Hayden, the conservatorship chair. Go ahead, Bertha.
Thank you. Good afternoon, all. My name is Bertha Sanchez Hayden. I'm with Batsadic Legal Services as the directing attorney, and I have the pleasure and privilege to be the chair for the conservatorship work group. At the conservatorship work group, we've been focusing on 7 key areas. One is, again, education, educating the public, professionals who work with older adults and adults with disabilities, and legislature about probate conservatorship and other decision-making tools, such as supported decision-making, advanced healthcare directives, estate planning tools. We also want to increase the visibility of those decision-making tools and estate planning tools. And we've been working to identify current data sources to be able to make recommendations on how to streamline and centralize data collection for probate conservatorships, as well as identify gaps in the conservatorship system and make recommendations to legislatures for improvements or augmentation of services for conservatees. Further, we also have been working to identify gaps in best practices or recommendations to service streamline referrals between adult protective services and public guardian programs, as well as provide recommendations to the legislature to create centralized oversight and provide funding to the public guardian programs. So with those core objectives in mind, over the past month, we have been focusing on certain activities. With our data collection, the subgroup had worked diligently to identify sources for different data on conservatorships, how many people are on conservatorships, what types of conservatorships in age group. But such centralized data simply does not exist at this time. So this subgroup decided to pivot to keep our eyes open for other understanding that the Judicial Council has just released an RFP to conduct certain data collection and put that particular objective on site. But we do want to articulate the importance for continued leadership around centralized data that can better help shape and inform programming. On the estate planning route, we were thankful to one of our members, who I believe is on, who connected us with the Prepare and Clarity professionals out of UCSF. Participants of the conservatorship work group, as well as other members of the EDJCC, were able to listen to a training on the Prepare tool. The Prepare tool is an innovative and accessible document available in different languages to help ensure and empower older adults and adults with disabilities to do their advanced planning. Hearing about the tools and hearing it from a clinical perspective, what we have to do to get these tools in the hands of older adults and adults with disabilities, as well as hearing how we can make sure as professionals to further disseminate their availability was helpful. And speaking on a personal level, it's helped myself, and a trickle-down effect has been that I'm connecting my own staff with this tool. And so we can keep the domino effect of sharing this critical information and just seeing what rich resources already exist and further enriching our communities with those resources. On our governance subgroup, the team has been working to identify how to further establish a state office for public guardian. And I think by highlighting the importance of some of the gaps that we're seeing and how having a state office on public guardian would serve to alleviate those gaps. On our education initiative, we are focusing on the fact that the ACL is releasing a new innovations funding that will be out in June. I think the RFP will be released in April, with it due in June, around that timeline. And so the group is working now to get that information to the proper individuals that could further take action and support and do our part to gather information to enrich that proposal so that we can see that as another resource to come to California and to improve our conservatorship system. Thank you for the time to provide the update.
Thank you, Bertha. Amazing work being led by Bertha Hayden and the conservatorship work group. Thank you so much for the update. Conservatorship does provide a little bit of flexibility on being able to manage, the changing needs for older adults and adults with disabilities, and furthering this work will definitely help with obtaining those services. So thank you so much. Next slide, please. At this time, we would like to open it up for committee questions and discussion. Carol, if you could go to gallery mode, please. Does any of the committee members have any questions for any of the chairs or the co-chair for the for the Elder and Disability Justice Coordinating Council work groups?
Not seeing any hands, Ranjana.
Okay, thank you, Carol. Next slide, please. At this time, I would like to go ahead and introduce everyone to Susan Rodriguez, the Assistant Director of the Office and Long-Term Care Patient Representative. Go ahead, Susan.
Ranjana, thank you so much. On behalf of the Department of Aging and the Office of the Long-Term Care Representative Program, I just want to thank you all for giving me the opportunity to talk about this new and important program. I also work with Regina with her public guardian work, so you all have seen me in that role as well. Next slide, please. So I'm just going to give an introduction to the program and give an oversight of what's happened over the course of the last year. We've actually only been operating since January of 2023, so it's been a quick 9 months, but we've been developing the program for a little over a year and a half. So we're a new program within the Department of Aging that was established by the Welfare and Institution Code 9260 that provides trained public patient representatives to participate in interdisciplinary team meetings held pursuant to Health and Safety Code Section 1418.8 and we serve specified residents of skilled nursing and intermediate care facilities. Ranjana, are there the
Next
okay.
slide, please.
Yeah, next slide. We can go on to slide 3. Thank you. Or the next one. We can go to the next one.
There we go.
So Health and Safety Code 1418.8 has actually been around since 1992. For those of you who've been in the aging field or had any work with facilities, skilled nursing facilities, you may remember EPL hearings or the EPL bill. Sometimes facilities refer to the interdisciplinary team process as a care plan or a multidisciplinary team. But throughout the years, 1418.8 was updated with the most specific, or with the most recent update being that facilities must include a patient representative whenever they convene an interdisciplinary team meeting to make medical decisions requiring informed consent for residents who lack capacity and have no legal surrogate. A big part of the change to this, to Health and Safety Code 1418.8 is that residents must get notices regarding the fact that there's going to be an interdisciplinary team meeting, and they need to do it. They need to give a notice before and after, and they also need to provide a notice to the patient representative once the meeting has occurred. They also are required to provide specific data to CDA, and we're in the process of collecting this data right now. Next slide. So the criteria for requesting a public patient representative. We get a lot of questions from the community about how to make a referral to our program. And we have a very narrow scope as far as what we're able to do. And the only way that we receive requests for a public patient representative is from a skilled nursing facility. We have a specific database that they use to request a public patient representative. And the criteria for that is the facilities will get an order from a physician, and that order requires, it discusses a medical intervention that requires informed consent, and then the IDT needs to be convened before that's administered. The attending physician determines that the resident lacks capacity to provide the consent. The resident has no legal decision maker, and they also do not have any family member or friend available or willing to participate in the interdisciplinary team review. And when we talk about willing, that's a subject that comes up a lot for us. Sometimes you have family members that may want to visit and be a part of the person's life, but they don't want to go to the point of making healthcare decisions for them. And we also find that a lot of family members sometimes are concerned that they may be held financially responsible, or they may have their own reasons for not wanting to be the patient representative. Next slide. We're going to talk a little bit about the public patient representative and the requirements of being a public patient representative. Next slide. So the eligibility to be a public patient representative, you do have to have a criminal record clearance. We go through the fingerprinting process with the Department of Justice. The individual must have no conflict of interest, which this includes they may not be a healthcare provider of the resident being represented. And within the last 2 years, they cannot have been compensated or had any type of financial interest or anything to do with any of the facilities where they're convening the interdisciplinary team review. They must complete an initial certification training, as well as keep up with continuing education hours to be a public patient representative. And our office provides all of that education. And we use both internal and external individuals to help us provide that training. The eligibility and certification also means that the public patient reps agree to follow mandated reporting responsibilities, and they also refer to legal services for any residents who seek judicial review. So if their capacity may be fluctuating and they are able to participate in the process, and they maybe don't agree with the outcome of the interdisciplinary team meeting, they do have the opportunity to seek judicial review. Next slide. So the overall role and responsibility of the public patient rep, as I mentioned in the beginning, it's a narrow role. We only go in on interdisciplinary team meetings pursuant to the Health and Safety Code. And so the responsibility of that means we confirm that the criteria are met. We meet, and if possible, interview the resident prior to an IDT meeting. And again, with this being so new, we weren't sure how the program was going to work and our bandwidth and how often we would be able to actually meet in person. And I'm very proud to say that we are meeting the majority of our residents in person prior to the IDT. Sometimes it's maybe a couple of days before, or it may be the day of, but we are definitely meeting these people in person, which is very important to us. The public patient representatives review medical and clinical records prior to the review, and how we get these records, it's either at the facility or the facilities actually upload information to us through a secure database. We review the facility's policies and procedures related to the process. We participate in the interdisciplinary team review, considering what's required by statute. We articulate the residents' preferences if known, or the best approximation of preferences. And if we're not able to do that, we look at what's in the residents' best interest based on review with the physician and the medical team. And some additional responsibilities, as I mentioned before, is mandated reporting and providing contact information to appropriate legal services. Next slide. So what is the scope of the responsibility of the public patient rep? So we cannot participate in interdisciplinary team reviews of a decision that would lead directly to death. Some examples of that would be a ventilator that assists with breathing. Potentially we cannot participate if it involves a feeding tube, but we always go back to the physician to have the discussion about all the different interventions and would it possibly lead to death, or is it just like the example of someone having a stroke and a speech issue, if they go off the feeding or swallowing issue, I'm sorry, and the feeding tube comes out and they're able to eat again, that wouldn't necessarily be the same as taking a feeding tube, discontinuing a feeding tube from someone who is not able to swallow at all. The most of the IDTs that we participate in and in which we have the authority to participate in are any types of orders related to a physician order for life-sustaining treatment, or a POLST, as many of you have probably heard of, do not resuscitate orders, comfort care orders, election of hospice care, and then the new psychotropic medication orders. And whenever we do these interdisciplinary team meetings for all of these, part of the statute says that we must review the intervention on a quarterly basis. So once we do the first intervention or the first meeting, then we will go back in the next quarter and review with the facility what's happened over the course of the last quarter. One of the big things that we look at in terms of the scope and the responsibility of the public patient representative is consensus must be achieved in the interdisciplinary team process in order for the intervention to occur. So if the public patient representative doesn't agree, then the intervention will not take place. So there's a lot of discussion with the resident and with the interdisciplinary team. Next slide. So we get a lot of questions in our office about some things that we can and can't do. So we like to share this information publicly. If it's not the role of the public patient representative, whose role is it then? We are not able to serve as a decision maker for residents for their fiduciary matters, for admission, or for placement. Some individuals who may participate in that would be a conservatorship or a guardian, a representative payee, a power of attorney or an agent for healthcare, or a family or a friend. We don't serve as case managers. Our criteria is very narrowly focused. We go in and do the interdisciplinary team review, and then we back out. We don't necessarily provide community resource referrals to residents and their families. We really defer that to the facility social worker, as they're the experts in the fields in their geographic area. We have public patient representatives all over the state. So we definitely refer to the facility social worker for the local resources. Another thing that we don't do is investigate elder or dependent adult abuse or neglect, and we don't necessarily resolve care issues. We would make any type of referrals for abuse or neglect to the long-term care ombudsman program, to the Department of Public Health, possibly Disability Rights of California, or any other type of investigative or enforcement agency that if we had concerns. And as far as care issues, if we notice something when we're in the facility, we would obviously make sure that the resident needs are met, but overall, any concerns that we have, we would definitely refer to the local, ombudsman program. Next slide. This is just an overview on our webpage, and this has all the history of the program and all the different requirements. This is a unique program at CDA. We actually provide the service in two ways. We have contracted providers that provide services in Los Angeles, San Bernardino, and Riverside counties, as well as Orange County. And then the Department of Aging and the Public Patient Representative Office actually provides the public patient rep services throughout the rest of the state. So it's been a wonderful experience working with our contracted providers and then with our state staff to provide coverage for the entire state. To give you an idea of what we've looked at so far and where we're at, we have had over 600 referrals for the program since January. We have approximately 200 referrals that are in progress right now, or active cases. I'm sorry, 22 that are active. We've participated in over 200 interdisciplinary team meetings. We've had a lot of denials. A big part of our job is going out and educating facilities. We've worked closely with our partners at the Department of Public Health. And then we've worked with the California Association of Healthcare Facilities, California Advocates for Nursing Home, to try and provide proper education out into the community as far as what we do. There's a little over 1,200 facilities that would potentially need our services. And we have about 80% of them signed up in our database system and to be able to make referrals and to submit data. Next slide. So at this time, I know that was a high level overview. I didn't know how much to get into the specifics of the law. So I'm happy to answer any questions. I see Jennifer asked the question, who can, if anyone, make a decision to withdraw a feeding tube or ventilation from an incapacitated or unrepresented resident? So that's a great question. We're not able to participate in that process. Facilities would potentially need to go down the route of I believe it's the code is 3200, and any of you conservatorship type people on here could maybe help with that as far as which code it is. But essentially the facilities that we can't help, that's not in the purview of the health and safety code for us to do that. Lisa, so you have a question?
Susan, just one second. Carol, if you can please go to gallery mode so the committee members can ask Susan questions if they'd like.
We're in gallery mode. Maybe Stephanie can take the slides down for momentarily. But we are in gallery mode. There we go.
Perfect.
Okay. Right. Lisa?
Thank you so much, Susan, for the presentation. I know a lot of us have been really curious about how the program is working. This is such a new program and innovative. I had a couple of questions. I guess one of them was, my understanding, you said that it would only be the facilities that make referrals to the program. I guess I'm kind of confused about that, because one of the purposes of the intervention was to avoid conflicts of interest. I'm just wondering if, for example, ombudsmen or others had situations, couldn't they make referrals, or would that not?
So the way that the referral process works is they have to submit the referral through the database, and only the facilities have access to a database. The ombudsman role, and Blanca, feel free to jump in with this as well, and the role of the patient rep are two very distinct roles. The ombudsman is there to advocate for the resident, and everything is on behalf of the resident. Whereas for the patient representative program, we don't have to have consent to go through the medical chart. If they don't have anybody, and if they're not able to communicate, we can still go through the medical record. Whereas my understanding with the ombudsman program, everything is driven by the resident, and our residents, for the most part, we're finding when the physicians say they don't have capacity, they really don't have capacity. So we're trying to represent them. We talk with the resident when we can, and we talk with the physician, and we go through the medical record, and we look for any type of documentation, whether it's a current physician or prior physician of the hospital. Did the resident make any declarations, or we'll talk to the certified nursing assistants, but it truly comes from the facility, and it's a very narrow scope related to the statute. Does that answer your question, Lisa?
Well, that answers it about the referrals wouldn't come from the patients, but you
Mhm.
say that a family member or an ombudsman became aware of a situation where they'd want to see an interdisciplinary team. They couldn't request that directly from you. It has to come. They have to.
So I guess one thing I should clarify is the Department of Aging, as well as our contractors, we go in and serve as the public patient representative, but we're not the oversight agency for the program. That comes from the Department of Public Health. So if the ombudsman program, let's say, becomes aware that a facility isn't utilizing public patient representative services, they could go to CDPH and file a complaint about that. But we can't accept the referral from the ombudsman. And if to have it come from family, if they had family, then potentially that family would be the one sitting in on the interdisciplinary team review. So it's a little tricky sometimes. I mean, we haven't, to be honest, we have not had, we have had a lot of dialogue with ombudsman about making referrals, but we don't get a lot of callers, like community callers of family members saying, can you help my mom or my grandma or whomever.
Okay, thank you.
Mm-hmm. Hi, Ellen.
Hi, Susan.
Good to see you.
It's good to see you. You know, I too am really excited to see this program get off the ground, a great need. My question was really, what are there any themes that are coming up in terms of the kinds of things that people are asking for help with?
Yeah, so the 4 or 5 areas that I mentioned in the presentation, so by statute, it very clearly says election of hospice, the do not resuscitate orders, the physician orders of life-sustaining treatment, and psychotropic medications are I would say our biggest ones. We're actually in the process of collecting our data. The facilities need to submit it by the end of the month. So we'll, in the next month or so, we'll be able to analyze all of our data, but just anecdotally looking at what we're seeing, those are the big areas that are specifically called out by statute. We've had a lot of referrals related to dental care. We've had referrals, I like to say our first IDT that we did was actually related to someone who had like a skin condition and needed to have something removed. And something else to be aware of, we're only doing interventions that are happening within the nursing home or the intermediate care facility. If it's at the hospital, that's a separate process. So, but those are the dental is the one that has surprised us, I would have to say. But we have had a lot about dental, but lots of do not resuscitate, post, hospice, comfort care, and psychotropic medications. Absolutely.
I think Marty also has a question posed.
Yeah. Just saw that. So thanks, Marty. I mentioned that it's sort of 600 people. Is there a waiting list or unmet need? So far, no, there's not an unmet need. We're very fortunate to have the staff for right now, but we need the more we go out there, the more referrals we get, but we are working very hard to meet those referrals of a very committed and passionate team of public patient representatives that are doing this. And when I say the 600, I mean, that's since the end of January that we've had that many referrals. And we haven't been able to quite narrow down how many facilities we've physically been to, but we've done all summer long. We called them lunch and learns, presentations to the facilities about our program. We've done individual technical assistance to facilities, as well as we've spoken with California Association of Health Facilities, like I mentioned earlier. So we've really just been trying to spread the word so that facilities do know that we're there and that it is a requirement. Keeping in mind, again, that we provide the service, but that public health has the oversight of the program. Blanca.
Susan Blanca.
Yeah.
Yeah, I just wanted to underscore that Susan from the very beginning has been very, and Lisa, very collaborative with the long-term care ombudsman. We have monthly meetings with our long-term care ombudsman coordinators. So even when the program stood up, she was providing ongoing updates because ombudsmen were very interested in how is this going to be different from what we do, and how do we, as you mentioned, if we know of a case, how do we refer? So we wanted to make sure we were following the protocol and also being aware of it. So ongoing, collaboration, I would say, and we recognize that this, if we can inform and educate the facilities, and we're there all the time, so we can talk with them also about this option.
Yeah, thanks, Blanca. Hi, Marty.
Hey, Marty Yamoto, family member, parent, California Disability, I forgot my organization, California Disability Aging Community Action Network. First of all, thank you so much, Susan, for this, and thank you to your team, for this new program. And I actually learned on the details that you provided because, I kind of had a surface idea about how this was working. And I do echo what Blanca was saying, that so not only for her staff, but probably for the people out in the communities, there might be confusion about the roles. And so I'm glad you clarified that here. And I think that's something as advocates, all of us are going to have to, do that, in the coming weeks and months. My question went, and thank you for answering the first part of my question in the chat. The other part was, is there data that I'm assuming you're collecting that is person-centered in terms of the referrals or the presence of the patient representative? Meaning, is there a difference that impacts that person's life with the presence of that patient representative? Meaning, in a referral, like what is the outcome when that happens, when the patient representative is there? Especially on the dental medications, whatever it is, because one of the big things is that we're all pushing for, right? And it's one of the principles of the Health and Human Services guiding principles, is looking at the outcomes that is based on the individual. That's not easy to do, but normally in health and human services, all the data that we get is utilization. So numbers served, numbers referred. But what I think we all want to know, and I'm sure that is your feeling too, is when you're participating and adding value to that referral, what happens to the individual when they are they getting better care? Are they getting a better outcome that meets their specific need? That's not easy to track all that. And so I don't mean to put this on you or to, be critical, like you don't have enough work to do, right? But I just want to put that out there and to see if that is going to be, one of the next steps. And I think that collectively as a group, we need to drive towards that person-centered outcomes tied to the need. And again, I'm going to thank you because this is such a tremendous need that you're trying to fill, Susan, and you and your team. Thank you.
Well, thank you, Marty, and thank you for the question. As we all know, collecting the person-centered data can be a challenge. At this point, we are still just trying to follow what the statute says in terms of data. So that is our first data point for right now, which includes what types of interdisciplinary team meetings occurred and the outcomes and how many specific residents, and there's a whole list of criteria in the statute. We do get a notice after the fact, so we do know what the outcome of the interdisciplinary team review is. So that's where we're at right now. And again, we're 9 months into this, so we'll keep plowing forward. Thank you again for your question and your support. Are there any other questions? Okay, with that, I will send it back to Carol.
Hey, everyone. I think we're going to go back to Susan DeMorris. She got cut off due to technical difficulties. So Susan, I'm going to spotlight you and we'll hear the rest of your updates. So if you could just give me a minute to find you. Where are you, Susan?
Got it, Carol.
Thank you. There, I see you. Great. Thanks, Susan.
Thank you. And my apologies. Poor timing on getting kicked off of Zoom. I was just about to, after thanking Eric, and I don't know if Eric had a chance to make comments. So before today's meeting ends, I want to be sure if Eric has any parting wisdom for the group, we get to hear from him. We also had put on the agenda, and I'll be sure to share in the chat, some work happening at the Department of Aging that is tangentially related to what we're talking about here today. So with the master plan for aging, you know, there's a big focus on navigation and how people find information, access information, and find their way. And that applies to everything we're talking about here today as well. So I just had a quick verbal update, not a lot of slides, just to share with you some exciting developments. The first is, you know, we think about an umbrella or the big tent, which is a no wrong door system, where people, older adults, people with disabilities, family caregivers can move with ease between programs, services, departments, and that wherever they land, the staff and volunteers who support them have the information they need to assist or to provide a warm handoff or referral to somebody who can be of more help to them. So we're really excited that we received funding from the Administration for Community Living to establish a No Wrong Door Governance Council at the state level. When we talk about things not working on the ground, sometimes that's a symptom of things not working up above. So, you know, as you know, in a state as large and complex as California, in an agency as vast as the Health and Human Services Agency, where we have Department of Healthcare Services, Department of Rehabilitation, Department of Developmental Services, Social Services, Healthcare Services. And then you look outside of the Health and Human Services Agency, the key services around transportation and housing that are represented by other cabinet agencies. So we're just starting the work on the No Wrong Door Governance Council and structure that will support our local efforts. So I wanted you to hear a little bit about that. And then nested within that would be our network of 33 area agencies on aging, the backbone for older adult services. We've been really engaged over the past year in an initiative referred to as California 2030. We established a steering committee that was made up of representatives of the area agencies on aging, the state independent living centers, counties, and county welfare directors. And we've been meeting for about a year, extensive individual interviews, focus groups, and a lot of data analysis and looking at best and model practices in our state and nationwide. So that work is coming to a close in the next month, and we'll be able to produce a public report that everyone will have access to. So we'll bring you more detail on that. And it's really how can we equip our AAAs to serve the population, a larger population, an older population, a more complex population, a more diverse population. So, you know, what can we do now to put in place the structures and systems and the governance that we need to be really strong by 2030. And then we have our Aging and Disability Resource Connection program that many of you are familiar with. Our legislature and prior governors made a commitment to the ADRC expansion, and we're thrilled that this is now in about half the counties in our state that we can point to an ADRC that's up and operational. And we're really looking at what's the next, you know, what's the sustainability plan for the ADRC program and model. And that is part of these conversations as well. We've done a SWOT analysis, strengths, weaknesses, opportunities, and threats. And that was followed by a business plan. So we're putting all of this together. We're working on it this fall. We've been sharing this out at different committees, the Disability, Aging, and Community Living Advisory Committee and other. We have an ADRC advisory committee. It's been, we've had other public meetings with the AAA network, with the caregiver resource centers and others. So today I just really wanted to flag for you more to come on this. We'll be talking in greater detail with you. These are all goals and initiatives within the master plan for aging. And in our view, these are critical next steps to build the LTSS infrastructure and capacity that we need we so desperately need in our state. So thank you to our team for sharing in the chat some of this activity. If you want to learn more, feel free to reach out. We'd be glad to give you a lot more information, but today it was really just a snapshot and a look at, and looking at Ellen, I forgot the California Commission on Aging is also a member of the steering committee and has been part of the California 2030 work from the outset. Does anybody have any questions for me? Not seeing any. Not seeing any. You know, as you know, thinking back to the landscape work that was done here too, for people that can't sleep at night, you might want to look at the California 2030 work, because it's really impressive in terms of looking at the demographics of our state and who we're serving today and who we'll be serving in the future. So there's a lot of rich data. We'll be synthesizing all of that for you. And when in the final report, it will be, you know, in a digestible format. But for anybody who's really interested, there's just some rich data there to take a look at. Thanks for the time on the agenda. And back to you, Ranjana.
Thank you, Susan. I will go ahead and pass it over to Carol so we can go and take a short break. Carol? You're muted, Carol. There we
I
go.
am muted. Thank you, everyone. We're going to take a short break, 10 minutes. So please go grab yourself something to drink, take a quick stretch, and we'll see you back. It is 2:03, approximately 2:13. Thank you.
Welcome back from break, everyone. Let's go ahead and resume our council meeting with renewed energy and focus. At this time, I would like to introduce you to Lee Bills from the Victim Services branch. She is the branch chief at the California Governor's Office of Emergency Services. Welcome, Lee.
Hi, everyone. Today I was asked to talk a little bit about the programs we have at CalOES that respond to the needs of elder and dependent adult victims of crime. So I put together a short presentation that talks about the Victim Services branch, who we are and what we do overall, including the fund sources that we oversee, and then some potential cuts that are worrisome for everyone in federal funding, and then highlighting 4 programs, specific programs that may be of interest. And do you want me to just indicate advanced slide?
Yes, please. Next slide.
So the mission of the Victim Services branch within CalOES is to provide technical assistance and support to victim service providers to ensure all victims and survivors in California receive the services they need. So I didn't realize that you all would be working the PowerPoint, so there is some animation, so you're going to have to click again to get the next portion. So the way we do this, or the way we attempt to accomplish this mission, is by creating programs that are trauma-informed and victim-centered. Next. Providing timely and consistent technical assistance to subrecipients so that they can spend more time serving victims of crime and less time on paperwork. And then last, but certainly not least, to ensure that we here in California comply with all the federal and state requirements so that we never jeopardize any of this crucial funding. Next slide. The branch as a whole is pretty large. We have 80 programs, about 80 staff people, and we oversee approximately 1,200 grant subawards. Next slide. At any given time, we have approximately 27 open federal awards. And the next slide will show you some of the funds that we oversee. But because federal awards often come with multiple years of operation, at any given time, we have approximately 27 open with 12 unique programs, 18 different fund sources, really only 3 fund sources, but 18 different specific programs these funds are required to support. And at any given time, we're managing about a $1.3 billion of funding for victims of crime. That does not mean that we give out 1.3 million a year. It just means we're responsible for knowing where that money went, where it is going, what was done with it, and reporting to the federal and state government on those fund sources. Next slide. This just shows you some of the federal grants, not all 12, I believe, but some of the main grants that we administer on the behalf of the state of California from the federal government. And if you could click, the Victims of Crime Act VOCA Victim Assistance Program is the one that is probably of most interest. It is seeing a reduction, and it funds half of the 80 programs that we have. Next slide. The Crime Victim Fund, so the VOCA Victim Assistance Formula Grant Program, and all of the programs authorized through the VOCA, the Victims of Crime Act, are supported through the Crime Victim Fund. And the Crime Victim Fund is fines and fees from federal crimes. Next slide. It was created as part of the VOCA when in 1984, when the act passed, they created the Crime Victim Fund. And it supports a variety of programs, not just the VOCA Victim Assistance or the VOCA Compensation Program at the Cal VCB, but a lot of other programs. CJA, at times, money has been diverted over to the Stop Violence Against Women, and then also the Anti-Terrorism Emergency Reserve Program, which supports a lot of efforts post-mass victimization. Next slide. So this really shows you the cap. And so there are multiple factors that go into how much California receives through the VOCA Victim Assistance Program. And the first piece of the puzzle is the cap. So you'll see here that the cap has varied significantly over the years. If you could hit advance, there you go. So in 2021, the cap was 1.093 billion. So just a tiny bit over a billion. The projected cap for 2024 is 1.2 billion, which is down from 1.9 billion, and is why we are starting to look at planning for eventual cuts. Next slide. This slide shows you the amount California has received through the VOCA Victim Assistance Program, and it shows you what the cap was the year that we received it. It's not a direct correlation because there's a lot of factors that go into determining how much money is available for the VOCA Victim Assistance Program. There are the set-asides that Congress establishes. There is the formula that feeds into the VOCA Victim Compensation Program, and then the portion that is required for the VOCA Victim Assistance and any money that was left over not used through the formula for the compensation program make up the VOCA Victim Assistance. So we really don't know what we're looking at, but we do have some projections. Next slide. And here you'll see we're projecting, and this is a very rough estimate, receiving approximately $100 million for this program. The highest was in 2018, where we received almost $400 million, and now we're looking to be down at about $100 million. Next slide. So the programs as a whole, we're still determining how we're going to administer the cuts. We're working with the focus steering committee and no firm decision has been made. So we don't know yet, but we know cuts are coming. There are some advocacy efforts at the state and federal level to find other sources to augment the crime victim fund, and also efforts to raise the cap, which would result hopefully in more funding coming to the states through the formula grant programs. But it's really uncertain. So unfortunately, and I know people really are very interested in knowing exactly what's going to happen, we just don't know. We don't know because there are too many unknowns at this point. We're waiting for the federal budget to pass. We're waiting to see how advocacy efforts at the state and federal level turn out. And it's just a lot of unknowns. So we don't know. We work with OVC, the Office for Victims of Crime, who administers this at the Department of Justice, the Federal Department of Justice. And they provide information as they can, but really they're guessing and projecting just like we are. What I can say is we're planning now for reductions that will start in fiscal year 2024-25. So no programs will be impacted. The soonest programs would be impacted would be in July, programs that start on July 1, 2024 or after. So if there's a program that starts 1/1/24, that there's funding for that program for the next year. It's just anytime we're talking about a program that would start July 1, 24 or after, we're likely going to see some kind of reductions. Competitive programs we are looking at in terms of the competitive programs that are going now and competitive programs going forward, looking at the potential to reduce the number of subrecipients because we anticipate that we won't be able to support them for the 5 years of the funding cycle. And we don't want to commit to funding that we aren't going to have, meaning we don't want to say for year one, we're going to fund 100 subrecipients and then in year two have to cut them all 50% or reduce the number at that time. So we're looking at reductions to those programs moving forward. 4 of the programs that I think are of particular interest to this group include, next slide, please. The first, well, let me just tell you what the 4 are. The elder abuse program, the legal assistance program, the specialized emergency housing program, and the underserved advocacy program. The first one I'm going to talk about is the elder abuse program. And this program is our main program that is focused solely on responding to the needs of elder independent adult survivors, victim survivors of crime. And this is a direct services and a collaboration to ensure that communities are looking at a multidisciplinary response. Next slide. This program was just released on September 28th, 2023 for the next competitive 5-year cycle. Proposals are due the 17th of November. So right now on our website, and I'll show you where it is later, you can go and look and submit a proposal anytime between now and November 17th to compete for funding. The maximum allocation for this program is $217,000, and the details of the program will be in the request for proposal. Next slide. The legal assistance program is our legal assistance, both criminal and civil legal assistance for survivors of crime, including specialized populations such as the elderly, such as dependent adults, such as Spanish-speaking survivors, whatever culturally specific providers, all of those groups can be prioritized within this program. Next slide. This shows you when subrecipients identified a population to focus on, what percent they focused on these different populations. And this particular one is crime type. So for elder abuse, 11% of the subrecipients in this program for fiscal year 22-23, we're just now starting to look at the 23-24, so I don't have statistics yet on what they'll be focusing on. But the previous cycle, 11% chose to focus on providing civil and criminal services, legal services to elders. Then the other thing I should point out is that this program is going competitive. It just went competitive this year, so it is scheduled to go competitive again in 2027-28. Next slide. The Specialized Emergency Housing Program. This program was really created with the needs of elderly in mind, specifically looking to potentially help APS in finding placements for elders when they need emergency shelter or emergency housing and the assistance that goes with that. Next slide. Here you'll see that 7% of subrecipients that chose a focus are focusing on elder abuse. And again, this program is not slated to go competitive, meaning we award funds for 5 years. So we have a competitive process and we commit to 5 years. The upside of that is it really creates stability for the subrecipients to know that they're going to have support for 5 full years before they have to compete again or potentially lose funding. However, 5 years is a long time to wait to compete. So it is a double-edged sword. Next slide. The Underserved Victim Advocacy and Outreach Program is an advocacy program, a direct service program with the goal of providing culturally appropriate services to victims, survivors of crime. So we're not just talking about here are the services, we're trying to tailor them toward whatever group the agency chose to focus on. Next slide. And this program does require them to choose either a crime type or a marginalized victim group. Here you'll see again, 7% of the subrecipients that are funded through this program chose to focus on elder abuse. And the next competitive cycle is 26-27. Next slide. I think most people know, but in case you don't, our website, you can go to apply for grants. Next slide. And then you'll see the search for grants. And if you click here, you will go to the next slide, which will show you all the open solicitations. The red arrow also shows you where you would go to get on our listserv. So our listserv is used for 2 purposes. One, for our competitive open funding. So you're not gonna, if it's a non-competitive program, meaning it's year 2, 3, 4, or 5 of once competitive process, or it's a non-competitive solicitation, meaning only one entity is eligible or a finite group is identified as eligible, you will not get an email. So you're not going to get 80 emails from us every year. You'll get an email for any open solicitation that is competitive and open to a large group of people. And you'll also get noticed of any public meetings we have. So we have several advisory bodies that help guide us in making recommendations for how to use the funding. So for this purpose, we use this mailing list as well, but we are very committed to only using it for those 2 needs and making sure that we're not flooding your emails. Because I know, like myself, many of you get tons of emails, and when you get multiple emails from the same listserv in a day, you start to tend to ignore them. So we wanted to avoid that. So we were really cognizant to be very selective in what we send out here. I did see in the chat, a question came up to what is considered a victim through the VOCA Victim Assistance Formula Grant Program, and it is very broad. It is anyone who has suffered physically, emotionally, financially due to the commission of a crime. So it's and what I get asked a lot is financial abuse for elderly, are they eligible? And the answer is definitely yes. That is considered a crime that is eligible under the VOCA Victim Assistance Formula Grant Program. Now we're at the point where we have questions. Does anyone have questions for me?
Thank you, Lee. This is very informative. If committee members have any questions, I know this is something that it was a focus during a work group, or work groups. Please feel free to ask those questions. I know Lisa has her hand up. Hi, Lisa.
Hi there, and hi, Lee.
Hi.
Thanks so much for being here. We worked closely together for many years and have just been so delighted by how Cal OES has been responsive to the needs of older crime victims. And I was just wondering if you could talk a little bit about some of the programs that you're funding now, especially the multidisciplinary teams and the legal services, because I think maybe not everyone on this call knows the breadth of the services that you're funding right now.
Sure. So, I'm not the right person to speak about individual subawards because there are 1,200 of them in our branch and we have 80 staff who know a lot more than I do. But I will say that the elder abuse program is a combination. You will see people doing really, and this is a core belief of ours at Cal OES and the Victim Services branch is that communities know best what they need to serve the people in their communities. So we aren't real rigid. So sometimes you will see a DA's office applying and partnering with APS and community-based organizations to do a multidisciplinary approach to identifying, to connecting, to serving elder abuse victims. That's very common. In terms of legal assistance, this is a really new and exciting area. And I guess it's not really that new. It's probably 6 or 7 years old now. But in 2000, maybe it was 2015. So now I'm dating myself. It's almost 8 years ago. We were allowed to start using these funds for criminal and civil assistance to victims of crime. And that's a real exciting area for us because it is a need. It's a huge need. And civil, we're talking about restraining orders. We're talking about family custody issues, lots of civil issues, but we're also talking about criminal cases. And there's kind of two areas where we talk about this. One is expungement. So we see a lot of folks arrested for prostitution when they are truly trafficked. And so we want to be able to allow for that. We also see people needing financial assistance around, legal assistance around financial abuse, identity theft. And then we even allow folks to go if there are a victim and just need to be represented in the criminal process as a victim of crime. So that's kind of the areas that we focus on. But again, we're very, very open in letting agencies define what kind of services they want to provide. The majority of our legal assistance service providers partner with an advocate because we have people coming for legal assistance, but they need a lot of other care as well. And so that's very, very, very common in what we do.
Thank you, Lee. Lisa, did you have any other questions? You're muted.
I'm good for now. Thank you. It looks like you have another hand up, though.
So, we do also have a question from Marty. He was not aware of the details, so this was really helpful. It's feedback. Thank you, Marty.
Thank you.
I
have a question too.
Howard, is that you?
Yeah, that's me.
Okay, thank you, Howard.
Yeah.
Go ahead.
My question is, can we do anything to get all the agency and program for crime victims and other victims of elderly abuse under one roof?
Is the question, does the program allow support to do that, to get everyone in under one roof collaborating?
Yeah, can we group everything together so that crime victims only have to make one stop and that they don't have to jump from agency to agency to agency?
Sure, that is something that people could do with the, through the elder abuse program, certainly allowable to coordinate and, create space so that there is kind of a one-stop shop. Of course, there is the family justice centers that, with the focus to do that, in some communities, not across the state, not in every community, but that is the goal of the Family Justice Center, to have a one-stop shop. Of course, it's not focused on services for just elders and dependent adults, but that is something that could be created in a community using the XE, that we call XE, the Elder Abuse Program, the funds for that program.
That would be very important because there's such a great need
Mhm.
to help people who are victims of elder crime and abuse. And what can be done? Is there anything that can be done to put these scammers out of business? You know, people who take advantage of their money and that kind of thing. Is there anything we could do to get these scammers off the market, off the web?
I'm not sure I'm the right person to answer that. Is there somebody else who knows what we could do to, I'm not sure who we're trying to remove from.
Oh, I'll
Because
just share that.
I get called for scammer literally every day, offering everything from greater Medicare benefit to funeral services.
Oh, okay. Yeah, that's not something that I know anything about, but I share the frustration, and I know it is, the problem is real. And certainly real for elders who are home and may answer their phone more than, say, you or I do.
I
Thank you, Lee. Bertha
I-
may have more information on that, Howard. Bertha?
Oh,
I- I
sure.
can-
How?
I can detect a scammer when they're coming, you know, they make it possible rewards and stuff like that. But a lot of elderly people don't know if a scammer called them, offering them a free vacation to Hawaii or whatever, they might jump at it, not knowing that it is a scam.
You're absolutely right, Howard. And at Betsedic, we're lucky enough to be one of the recipients of one of the UV grants, and one of the things that we've prioritized and trying to help with that. And maybe I can get you can direct message me your email, and I can connect you with our program advocate that can help with providing the resources and how to get your number blocked or try to further prevent those calls. But one thing we really believe is being boots on the ground and helping disseminate quickly what scams look like. Like, for instance, there was a new scam with somebody catfishing people on Instagram, like messaging you saying like, oh, I'm a radio host and I really appreciate if you could send in a donation. So I just want to give a shout out to like the big impact that the Cal OES UV grants have helped us. You know, we have a social worker and a program advocate because of that Cal OES funding that allows the attorneys to do the legal services in order when something does go wrong. But the Cal OES UV really does also help with those prevention services to quickly cut off scammers as they get more and more sophisticated, and further disseminate with other professionals or other community members who are the right people in terms of local law enforcement, FBI agents that like full focus on like the elder abuse wire scams, to make sure seniors are quickly connected with the law enforcement to stop the scam, but also to further prevent at the exploitation. So I'll look for your email, or I'll check Ranjana, and might be able to share some resources on how to prevent scammers from further calling your phone number.
Thank you very much. Thank you for your answer, and we should have to do everything we can to make sure that elderly people don't get scammed by people offering everything from unexpected benefit from Medicare to, as I say, funeral services.
Thank you, Howard. Lisa?
Well, I would just add to that that this is a huge problem, and it's so many different aspects of it. One of the things that we at CJC have been doing, we have our A team has been looking at working with banks to try to figure out what the role of banks in stopping transactions from going through. So that's one end of it. There's also looking at the law enforcement pieces of it. But I think, the point that that Bertha's making is it's really so much easier. Well, it's not easy. Nothing is easy when it comes to financial exploitation and scams, but prevention is certainly more straightforward than trying to prosecute and get money back. But those are also issues. And if you want to know more about financial abuse, we have a lot in the California Elder Justice Coalition's new blueprint. So it gives you kind of a scope of how it's being addressed from kind of prevention, prosecution, just the role of trying to interrupt scams as they're happening and turning them around. I'll put our web address in the chat.
Thank you, Lisa. I went ahead and put the information in the chat for you. Does anyone have any committee member have any additional questions for Lee? Carol, please let me know if I missed anyone and if their hands are raised.
No hands are raised.
Okay, thank you so much, Lee. This was very informative. We appreciate you presenting for Cal OES. Thank you. Next, I'd like to introduce my colleague, Regina Wright, who is the State Public Guardian Liaison, to provide information on the State Public Guardian work that she's been leading. Regina?
Thank you, Ranjana, for the introduction. So hi, everyone. My name is Regina Wright, and I work for the California Department of Aging as the State Public Guardian Liaison. So one of my primary objectives today is to get you familiar with my position, the creation of my position, who I am, and some activities that I've been doing. I will be giving some highlights from the 2023 Public Guardian Survey of just some areas that I've been focused on. Here is my contact information. My email address is right there. Please feel free to email me. I'll also put it in the chat. Next slide, please. So some background about the creation of my position. So my position as the State Public Guardian Liaison, it was created in the California Department of Aging's 2021-2022 budget change proposal for the Master Plan for Aging implementation. So again, my position was funded through a budget change proposal specifically related to the Master Plan for Aging. When the slides go out, you'll be able to click on the link, and that'll take you directly to the budget change proposal, so you can see that exact language. State Public Guardian Liaison is my working title, but for those of you who are familiar with State of California classifications, my classification is a Staff Services Manager 2, managerial, which is a mid-level manager who is a specialist so I don't supervise anybody. I'm more or less a team of one who's at the mid-level manager position. I just wanted to give that context as far as, because it can be kind of confusing about like what level my position is. I'm definitely not a governor appointee, so please know that I'm walking out of here, but I'm also not I'm not an analyst either. So I'm at the mid-level manager position. My purpose is to serve as CDA's liaison with county public guardian programs and conduct research on probate conservatorship, to formulate strategies to improve the quality of and access to probate conservatorship statewide, with the goal of protecting vulnerable individuals from abuse, neglect, exploitation, and self-neglect. And I've been in the position since November of last year, so a little bit less than a year. Next slide, please. So just some quick definitions to talk about the terminology we use in California about these issues. So probate conservatorship is a legal process in which one person, known as the conservator, petitions the probate court to care for another person, known as the conservatee, because they can no longer care for themselves and or manage their own financial affairs. The most common type of individual in a probate conservatorship is an older adult with dementia. And this is distinctly different and is a different type of conservatorship from what is known as LPS conservatorship, also known as Lanterman Petra Short, which is another legal process when a probate court determines that an individual is unable to provide food, clothing, and shelter for themselves due to a mental health disorder. So I just wanted to, so when you look at like the national conversation, like nationwide outside of California, you might hear the term guardianship, but in California, guardianship actually refers to minors for individuals under the age of 18. So unfortunately, you know, nationwide, we don't talk about these issues the same way. So what you might hear about guardianship nationwide, we're talking about probate conservatorship when it comes to older adults with dementia, or LPS conservatorship for somebody who has a mental health disorder. It is possible for an individual to have both a probate conservatorship and an LPS conservatorship. It does happen, but these are two distinct things. And my position only focuses on probate conservatorship. So today I only can answer questions related to probate conservatorship. It's not within the scope of my duties about LPS. If you could, next slide, please. So a little bit about the public guardian. So the public guardian is a county program that can administer a probate conservatorship if there are no family or friends that are able and willing to serve as the conservator. This is considered an option of last resort and is only pursued after due diligence is performed to identify less restrictive alternatives. So in my role, which is primarily a research role, I serve as a subject matter expert for probate conservatorship, and I serve as a liaison to the county public guardians. So again, the public guardians are county programs that administer probate conservatorships if friends and family are unable and willing to act. Next slide, please. So I wanted to give some brief information about the 2023 Public Guardian Survey. So I've been in my role a little bit less than a year, and one of my primary goals is to collect information about probate conservatorship. And I've been doing this through administering what I've been calling the 2023 Public Guardian Survey. So I'm going to give a few details and focus areas today, but this is, I have like sort of a mountain of data that I still have to analyze. So this presentation will more give you an area of like some high level areas that I'm focusing on. But again, there's a mountain of data that I still need to review. So the 2023 Public Guardian Survey, it started with a survey conducted through SurveyMonkey, May through June of this year, in this year, 2023. And again, it focused on only probate conservatorship as administered through the public guardian. So there are 58 counties in California. 57 counties completed the survey. Contra Costa County was the only county that didn't complete the survey. And then out of the 58 counties, actually 57 do have an office of the public guardian. San Benito County is the only county that does not have a public guardian dedicated towards probate conservatorship. I want to give a shout out to the California State Association of Public Administrators, Public Guardians, and Public Conservators, who provided the contact information for the public guardian. So those of you who have administered a survey know that in order to administer a survey, you need to know the appropriate contact information of who to survey. So the California State Association of Public Administrators, Public Guardians, and Public Conservators has been absolutely instrumental in helping me conduct this survey. Next slide, please. So when we're looking at what are the largest sources of referrals to the public guardian statewide for probate conservatorship, I identified 4 different areas through the survey. So most referrals, the number 1 referral source is through adult protective services, followed by the number 2 source is through hospitals. And by hospitals, I mean acute care hospitals and emergency rooms. Number 3 is through skilled nursing facilities, and number 4 is through the probate court. And so this is looking statewide, with all fit, this is looking statewide. This is not breaking it up into like extra small, small, medium, large, extra large, where there could be some differences. And folks can feel free to ask questions about this list during the comment section. Next slide, please. So as far as surveying what are some difficulties the public guardians facing, 96% of public guardians experience difficulty finding appropriate placement for probate conservatees. And placement, by placement, I mean where the conservatee or client is going to live, just finding an appropriate place for them to live. 89% experience difficulties with funding in their program, and 66% said they had difficulties with staffing. Next slide, please. And so here are some more granular details that'll be available when you look at the slides, but some specific examples about issues related to the placement options is that if a client has behavioral health issues, or if they have a traumatic brain injury, or if they have a criminal history, those factors can make things harder to place. Facilities, they have they can kind of refuse people, they don't have to take somebody who's difficult. And so the more sort of factors in place can really make it hard for somebody just to have a place to live. Related to lack of placement, like concerns about like the lack of bed availability, especially in the county. Not every county has, lots of options when it comes to the types of facility and the different levels of care. And so the public guardian will have to frequently place out of county. There's, issues with the lack of emergency placement options if you need to place somebody right away, limited availability. Concerns were expressed about the lack of access to affordable assisted living facilities, which could be a level of care that can be prohibitively expensive if a client is private pay. Concerns about facilities that don't offer dementia care, and again, the public guardian having to go all over the state in order to find an appropriate facility. So again, this was like a huge issue statewide. Feel free to ask any questions about this category in the questions. So some of the other, and placement in particular is something I'm looking closely at in my role, just because it's been expressed over and over again as a huge issue. Lack of funding, so clients who don't have financial resources to pay for their level of care, is a huge concern. Lack of staffing, so recruiting and retaining qualified professionals, was expressed as an issue, and an increase in referrals resulting in high caseloads for the public guardian staff. Some of the other categories like lack of support and partnerships. So some of the public guardians express they feel a lack of support from their board of supervisors and their county administrative officer, that they face difficulties with banks and financial institutions, difficulty obtaining capacity declarations in order to set up the conservatorship, doctors who are unwilling to testify in court about the capacity declaration, issues with county council staffing, that, county council would be involved in setting up the conservatorship, issues with the probate court having a backlog where just to get something on calendar can take a while in several counties. And one of the counties expressed concern that there was no direct guidance by the state on policies and procedures. So the public guardian is completely county run. The state has absolutely no involvement. The state has no oversight, no involvement. And so each county, has their own program and has their own policies and procedures, and that can look very different county to county. Lack of education about what the public guardian does. And so what does the public guardian do? you know, beyond like, like what does the public guardian do and what are they capable of and what can they not help with? So more education needed there about just the role of the public guardian and what services they can provide and what services they aren't able to provide. Next slide, please. So, I conducted a survey on SurveyMonkey to collect some information from the public guardians, again, in which 57 out of 58 counties participated. And as a follow-up to that, the SurveyMonkey asked, are you willing to do a follow-up interview? So out of those 57 counties, I was able to conduct a follow-up interview with 53 of the counties. And those were conducted July through September. So it just concluded the end of last month. And these interviews were an hour and a half interviews that kind of did additional follow-up to ask about the types of referrals. So more information about the adult protective services referrals and the hospital referrals. And so again, I'm sitting on like sort of a mountain of data right now that I have just begun the analysis. So the results of these interviews will be forthcoming. I'm at the very, very early stages right now, but I have been able to sort of compile this data and I'm excited to kind of go through it. And, and I'm excited to go through it. So next slide, please. So I'm happy to answer any questions that anyone has.
I see a hand up. Ellen has a question. Regina.
Regina,
Hi, Ellen.
hi, it's so exciting to see a lot of your data reach the public.
Hello.
Congratulations, you've been working hard. The one question I have, you mentioned financial issues for the conservatees, but what about for the programs themselves? Did that issue come up related to how the programs are funded? Some of them may receive additional money from the county, or it's just fee-based, or was that an issue that arose?
Yes, that is an issue that arose. So the county, so they have, every single public guardian, literally every single one has expressed issues about funding for their program. One of the things I learned in the interview is that because I'm in a unique position that my position focuses only on probate conservatorship, but in the vast majority of counties, probate conservatorship doesn't have like a separate bucket, so the majority of programs, about 75% of the time, the public guardian also administers LPS conservatorship, and they have this exact same budget. So when I asked the counties during the interview, can you please tell me what your probate budget is? They literally can't answer that question because it's a combined budget. There was only a handful of counties. And again, I'm at the very beginning of the data analysis, so I can't give too many details because I'm going through it myself. But that was definitely a finding, is that the way it's kind of set up is very intermingled, especially between LPS conservatorship and probate conservatorship. But even with those programs who also have the public administrator, which is about 50% of the time, the county budget is for PA, PG, and PC. So public administrator, public guardian, public conservator. So that kind of creates an inherent that there's 3 different programs. There's at least 2, perhaps 3 different programs who are all like having to utilize the same amount of money. I asked about conservatorship fees and, and the conservatorship fee schedule, because the public guardian is able to collect fees for administering the conservatorship. But any fees that are collected are only to offset the county general fund money. So it's not like you collect conservatorship fees and that goes towards the conservatee's care. It's really only to offset money for the general fund. But yeah, just to underscore, Ellen, that was across the board like a huge issue. What surprised me is that there was even more concerns about placement than funding for the program, which kind of shows how dire the need is for placement. But absolutely, the public guardians are struggling to fund their programs. And then we have another question from says EDJCC panelist link.
I've asked, okay, to rename. I don't know who that is.
Janie Whiteford. I'm with SECA, California IHSS Consumer Alliance. Sometimes we run into a relationship between a provider and a consumer on IHSS. And the provider, the consumer is in the guardianship program, but the guardian is with a private agency, with a private lawyer. How often do the counties actually do placements outside of the guardian's office into a private entity?
And that you came across that example in California?
Yep. Yeah.
Okay. I actually, so in my experience, interviewing the public guardians, nobody told me about, I'm actually unaware of that. Are you sure the public guardian is involved in that and it's not just a private conservatorship?
Now that you say that, I'm not sure. So it might be a private conservatorship. So that
Yeah.
When is the situation when that would occur? Would a judge go through that process? Is that adjudicated?
So what might happen is, like, let's say there's somebody, so the public guardian only gets involved as an absolute last resort. So that means that, friends or family would need to be, so to kind of circle back to some other information. So I found that the number one source of probate conservatorship referrals for the public guardian come through Adult Protective Services. So before that referral is made, either from Adult Protective Services or another referring party, they have to, it needs to be determined, are there any family or friends available? If they are, they would serve as the conservator. Sometimes if somebody has a very large estate that has to have complicated assets, a private conservator might be hired to administer, the conservatorship of the estate for the financial resources. The public guardian, I mean, the judge could, let's say you have two family members who are sort of squabbling and they both want to be the conservator. The judge has the ability to say that neither one are appropriate and to appoint either the public guardian or a private professional fiduciary. But there's never, in general, it's pretty, either the public guardian has the case or a private professional has the case or a family member has the case. There's not usually multiple people involved. And the public guardian actually expressed to me that they strongly prefer not to share the conservatorship with somebody else because it makes things rather complicated. So I'm wondering whether in the case that you are referring to, if it's a private, what's called a private professional fiduciary, who is the conservator. But feel free to, I don't provide, so just again, the scope of my role, I don't provide technical assistance on any, current conservatorship or trying to terminate a conservatorship or to set one up. But, I would be curious if, in this case, if, I don't know, the public guardian had conservatorship of the person and a private professional had conservatorship of the estate, but I'm kind of guessing that it's probably only a private professional and the public guardian's not involved.
So what happens if the public guardian office doesn't have the bandwidth to take care of all the people that are, sent to them?
That's an excellent question. I think that kind of highlights like sort of the dire need, is that if the public guardian, doesn't have, again, the state has no involvement, right? So if the public guardian only has county general fund and they're sharing it with potentially LPS conservatorship and public administrator, they're going to have a limited budget. So this you're kind of highlighting, a real critical issue here is that there is a capacity issue where, if the capacity of referrals is more than the public guardian can handle, then those people are not being served.
Thank you.
Yeah, absolutely. Any other questions?
I think I saw Howard's hand up earlier. Howard, are you still on?
Sorry, Howard, I did see your hand if you're still here.
Lisa.
Hi,
has a
Lisa.
question.
Hi there, me again. I just wanted to, I don't have a question. I just wanted to really applaud the department for doing this work. I think it's absolutely shocking that it's taken this long for us to even get this very basic information about public guardianship. And it's going to be so valuable to all of the groups that are looking at probate conservatorship. You know, it's been too long that we haven't had this information. So thank you to you, Regina, and also to the department for really moving us forward. This really is an underserved population.
Yeah, thank you, Lisa.
Any other questions or comments from the committee? Go ahead, Regina.
Oh yeah, I'm not seeing any other hands up.
Bertha is echoing Lisa's comment. And your update on the survey results. And you're doing phenomenal work, Regina. So thank you so much for all the work that you're doing for conservatorship. Alicia Morales is echoing the sentiments as well.
And I just wanted to say, if you are with an organization that has an interest in probate conservatorship and we haven't had a chance to have a meet and greet yet, I'm happy to set up a meet and greet so you can I can get to know about your organization and your interest in probate conservatorship, and you know, tell you any other questions you have about my position. And with that, I'll turn it over to Carol.
Hi, everyone. This is the time for public comment. So if we can get the public comment slide up. Okay. So this is our public comment time. We would, if you would like to make a public comment and you are a participant, please raise your hand using the Zoom webinar functions. You can raise your hand and then we will call on you and unmute your line. Attendees joining by phone, please press *9 on your dial pad to raise your hand and we'll unmute your line. And of course, if you would like to send a written comment, you may do so to our Engage email box, which is engage, ENGAGE at aging.ca.gov. So I'm going to go over to the attendees and we have a hand up from Heather Taylor. So I've unmuted your line, Heather, if you can go ahead, give your comment.
Hi, can you hear me?
We can, thank you, go ahead.
Hi, I'm a paramedic in San Diego County. I've reported several of the skilled nursing facilities for neglect on patients. And I am attending this meeting today because I've been kind of getting the runaround from the ombudsman. They're telling me that I need to make a report to the police, and then the police tell me to make a report to APS, and then they refer that report to the ombudsman. So going back to the director of APS, Achilles, he was talking about not enough cross-reporting being done. I was just wondering what is the most efficient way for me to report neglect in these nursing facilities at this time, because it doesn't seem to be working as far as like reporting to APS and the ombudsman and the police department.
Regina, I'd like to take that if I may.
Go ahead. Let me.
Yeah, this is Blanca.
Blanca.
I would welcome learning what, and you can reach out to me directly in regards to when there is neglect that you observe in a skilled nursing facility. We are the point of contact, and we should be a long-term care ombudsman should be the point of contact, and we would cross-report if necessary to APS. So I would need to know your specific case, and if you are getting the runaround, I would be happy to help facilitate that, getting some immediate action on this. It sounds like you're frustrated, and I want to make sure that you get the attention you need. But ordinarily, and rule of thumb is if neglect or abuse occurs within a long-term care facility, skilled nursing, RCFB assisted living, that you would contact APS. Certainly if there's an immediate a situation where somebody is seriously hurt, you would contact law enforcement, but you would report to long-term care ombudsman first.
Okay. So you're saying in the future, if I witness any kind of neglect, and for example, these are patients where I'm going to pick them up and transport them to a hospital for an acute medical need. So they're in the emergency department's care when I'm making this report. They're not still at the facility. So I don't know what jurisdiction handles patients that are taken out of the facility and put into emergency department.
That's an important detail, because anything can happen once they are in the hospital. So what I would recommend, because of the individual, in this case, you're transporting them and they are in the hospital. We don't have jurisdiction in the hospital, and that's why the ombudsman was telling you that. We don't have jurisdiction, so we can't go even in there and interview. We also have we are required to get consent from the resident before we open an investigation. So it may be more efficient to have APS do the investigation, but we always work with APS, and we will do cross-reporting. Okay,
so I should always report to APS in these situations, is what you're saying?
Because because the state long-term care ombudsman does not have jurisdiction, that means we can't go in and ask the resident, can we investigate this, and get their consent, which is one of the requirements before we even open a complaint or an investigation. Whereas APS, Adult Protective Services, does not have that requirement under their regulations.
Okay, great. Thank you for your clarification. I appreciate that.
Absolutely. Thanks for bringing this up. That's right, Lisa. This really speaks to the need for better coordination among reporting, and we should still have a cross report from APS. So when you contact APS, you can let them know, please, they should cross report, and they usually will send us the SOC 341, even though they may be the lead in the investigation. And that's only because the resident is now in the hospital.
Thank you, Blanca. Any more public comments? If you want to use your Zoom functions, your raised hand, we have a raised hand.
This Achilles Cerrone. I just wanted to add some comments to that question that we just heard. And I think this example illustrates some of the problems we have had with having the right agencies involved, and hence the thought of the one-door reporting, so that an individual can report once and the appropriate cross reports will go, for example, to the Bureau of Medical Fraud and Elder Abuse, who can investigate a long-term care facility or licensing and so forth, given the issues that were just discussed. Where is the patient? Are they in the hospital? Are they going back? Where did the abuse happen? One thing that it is important, and this is more of local advocacy and education with local law enforcement, and also calling the local APS to request assistance with some of these advocacy, because law enforcement can receive and respond to reports regardless of whether the patient is in a licensed facility or the hospital or living independently. And if there is an issue that is concerning, they should take a report and initiate an investigation and involve the other parties as well. So I really appreciate this example because it happens quite a bit. And like Blanca mentioned, if the resident cannot consent, but there is abuse and neglect, then what happens, correct? And also, if there is grave bodily injury, substantial risk, law enforcement is also expected to come in and investigate those reports. Is within their jurisdiction. So we have a long way to go, but it begins with these conversations at the local level, because every jurisdiction may have various levels of working together. And sometimes it really takes speaking with the managers of these agencies or commanders of law enforcement who can take appropriate steps to investigate these reports.
Thank you, Achilles. Any other public comments? Okay. Susan, I don't see any more hands raised. I think we can conclude public comment period. Of course, you can always send your written comments to engage@aging.ca.gov. So now I am going to turn it over to Susan Morris. Thank you.
All right. Thank you so much, Carol, and everybody who contributed to today's agenda. This is a miracle to be ahead of schedule. So I just want to compliment everyone for being so well prepared and so succinct. And clearly you covered everything in your remarks because there weren't a lot of questions. I believe Eric is Eric still with us? I can thank him in his absence for his time as our co-chair, and know that he will continue his work on the Master Plan for Aging Impact Committee. Did Jim want to make any comments now that he's joined us before we close out the meeting?
Let me
not to put him on the spot, but
sorry for the technical glitches. Sorry, I was in another meeting regarding the ACL proposed regulations for adult protective services, so that's why I'm late. But
well, you worked hard to get here, so I want to make sure you can make some remarks if you'd like to, Jim.
No, just appreciation for all of the leadership in the subgroups and with the chairs. That really, it feels like we're gaining momentum, and I think there's a lot of exciting efforts underway and a lot of exciting efforts to come. So I think, as you've heard, I'm really encouraged and excited by all of the conversations that are happening with many of the departments in the room. And I think it's a real step in the right direction towards, what the case example we just talked about really brings up, that coordination, those transitions and making sure we're doing that in a thoughtful and effective way between programs. So just lots of good stuff happening, and I'm always excited to be here because it really demonstrates the progress we're making.
Great. We're glad you joined. And I think today was a clear demonstration of the progress. And when I think of the Office of the Patient Representative that's only been in existence less than a year, and Regina's work also, to be reporting out outcomes and data and results, and, really building a foundation that together we can all work inside and outside of government and together in collaboration to really build a better system for older adults, people with disabilities who really are counting on us. And to, really be thinking, it came up over and over today too, about the ease of access and streamlining. Anyone who encounters our system is in difficulty or in crisis. And so what we can all do together in collaboration and in partnership to ease that difficult journey, whether it's the individual who is the victim or the professional who's trying to assist. So I appreciated the public comment also that came in, and I'm just heartened that we have an EMS provider working in our state who is so conscientious that she would join this meeting today to bring that public comment forward. So thank you all very much for your time today, your contributions to the meeting, to the CDA staff who pulled this all together. Thank you. And for what you do every day as volunteers or in your professional capacities. Most of all, I thank you for that. Thank you for a great meeting, and we'll see you next time. Bye-bye.